We are hosting this session on the unceded and ancestral territory of the Coast Salish peoples. That includes the territories of the Musqueam, Squamish, Tsleil-Waututh nations, and the Métis Charter community of the Lower Mainland. As you know, we're very committed to truth and reconciliation and understanding the land that we're on, the people that have tended it, and how to improve the health of both, actually. So wherever you are in this province or anywhere on Turtle Island, we all try and learn more about where we are, what we're doing, and why we're doing it. So this is Province-Wide Rounds. This is a collaboration between the University of British Columbia Division of Nephrology and BC Renal. This is kindly hosted by us, for us, and with the support of a number of industry partners, as well as all of you and all the different health authorities, and they're all listed here for completeness. And so it really gives me great pleasure to introduce Dr. Mathieu Lemaire. He finished his medical training at McGill, and some of you went to school with him, and then moved to Toronto to do pediatrics at Sick Children's. And after he finished his pediatric nephrology in Toronto, he went to Yale to do a PhD in investigative genetics of rare pediatric diseases. And so there are very few people in the country, let alone the world, that have this extra training. And so we're really thrilled that he's here. He discovered 2 novel forms of atypical hemolytic uremia syndrome using exome sequencing. And he then came back to the U of T, where he's now an associate professor of pediatrics, and joined the division of nephrology at Sick Kids as a staff physician in cell biology, program director at the Research Institute. He's a scientist there, so he's a clinician scientist at Sick Kids. And I first met him a long time ago when he was part of the Crescent program as a research fellow, and then became a new investigator. He does have a clinical practice focused on rare genetic diseases affecting the kidneys of children, and that includes glomerular, cystic, metabolic, and tubular conditions. And he has done many, many things, but most excitingly, he actually met with our fellows yesterday and tried to get them excited about how important it is to have to think about genetic diseases in the context of kidney diseases. He has worked with Mitch Halpern and others in a former life as a medical student on electrolytes. And so he has a diverse range of interests, but also of discoveries. So it's really a great pleasure for Mathieu to talk to us about hyperoxaluria. Over to you.
Great. Thanks, Adira, for the kind introduction. So it's a pleasure for me to be here today to tell you about primary hyperoxaluria. So I've been giving this lecture quite a few times so far, because there's a growing interest in this condition, because we now have some therapies. And at Sick Kids, we have a fair bit of experience with this condition. So here are my disclosures, and I should point out that Alnilam is sponsoring this talk, but they do not have any input on the content of the slides. So if there's anything that is not correct, it's my problem, and you can point it out to me. So these are the objectives. So we'll learn about the biology of oxalate. We'll talk about primary versus secondary hyperoxaluria. We'll learn about the clinical characteristics of primary hyperoxaluria, including genetics. And we'll talk, of course, about the old and new therapies for this condition. So here's the outline, similar process. I just wanted to give a tribute to Dr. Elizabeth Harvey. She was one of my mentors. She was at Sick Kids for almost 35 years. She was a massive person in dialysis, but also in kidney stones. And in particular, she had a very long-standing interest in primary hyperoxaluria. And when she retired last year, she came to me. She's like, actually to me and Sita Radhakrishnan, she thought we would be the right people, because you need 2 people to replace Liz. So Sita is taking care more of the sort of day-to-day clinical work with the stone patients, and I was helping with the genetic part, and also with the siRNA therapy. So this is our team at Sick Kids, and the reason why I'm plugging them, beside the fact that we work together on this, we are really keen to help you. So if you discover a new patient in your clinic and you're really unsure how you should proceed, particularly with the transplant setting, we are more than happy to help. So the 3 of us, including Chi Wei Teo, who's are basically the head of our transplant program, we have built significant expertise in this context, and I'll tell you some of the cases we've done recently, where we did kidney alone transplant instead of doing a dual liver kidney. Just a plug. So I work on the rare genetic diseases. I just wanted to let you know. So I'm working on a new form of Little syndrome that is caused by recessive mutation in a gene called NET4L. So if you have a little patient that has no mutation in the ENAC subunits, come and talk to me because I'm looking for patients. I also wanted to plug CaNGen. I'm not sure if you've heard about this. This is a new group where basically all the people interested in kidney genetics in Canada got together because we wanted to come up with some guidelines to help provinces, guide genetic testing, funding, and all of that. So stay tuned. It's brand new. We don't have a website yet, but we have a logo. So I guess it's real. And we're meeting every month. So also, if you have fellows that are interested in kidney genetics, or if you are interested, you're we'd be more than happy to have you come along. We have talks every month about interesting cases and discussions. So just email us or email me. So we'll start with a case. This is a patient actually I saw when I arrived on staff at SickKids. So this is an 8-month-old female with a failure to thrive since 2 months of age. And I guess at that point, 6 months later, a doc decided to do some blood work. And what was remarkable is her creatinine was 634 for an 8-month-old. It's clearly very high. Urea was 47. Her electrolytes were quite off, to say the least. And the sodium was 106. And she was anuric. So, and it turned out to be primary hyperoxaluria type 1. I'm giving you here the urine profile, which is, we'll talk about that a little bit later. And her ultrasound is shown here. I think you can see clearly the delineation of a very bright kidney. So right away we knew, actually that was Dr. Harvey. She's like, this is primary hyperoxaluria before we got any of the results. And she was anuric. So we ended up having to do custom dialysis because of the sodium 106. If you're interested to learn about this, we reported in KI report. There's a recipe to do this safely, and it is the most beautiful sodium you've ever seen. And this is the clinical course for this patient. So you'll see some of these graphs along the top. So the failure to thrive and stage, she ended up getting quite a bit of dialysis. You need to do a lot of dialysis with these patients. Typically, more than 2 hours is not helpful, and we'll talk about why. And sometimes in these patients, we do 6 or 7 times a week, basically every day. She ended up, this is almost 10 years ago. So she got a liver first from her mom and a kidney after. So this was a typical sequential. So you can do the 2 of them together, which is a bit more risky. In this case, she got the liver first and the kidney after, and has been doing very well. She had a compound heterozygous mutation in AGXT. And this is her course. No surprise there. She did very well when she got the kidney transplant. She has a normal liver now, so the enzyme that is deficient is replaced. And her growth picked up, and she's been doing very, very well ever since. So, so now, what about the pathophysiology? So what's going on? So no surprise there. It's a problem with increased oxalate in the plasma. It affects all tissues, but the kidney is a particularly, it's one of the main targets in terms of dysfunction. And the cause basically is decreased glyoxylate metabolism. And the relevant tissue for that is the hepatocyte. Remember I was telling you about liver transplant? Well, this is because this enzyme is expressed in the hepatocyte. And in cartoon here, let's see, we've got all the different, this is a hepatocyte with the different enzymes that are affected in pH1, pH2, and pH3. And as you probably remember from med school, if you have an enzyme that's not working, it will affect the substrate in the product. And you can easily map what are the expected biochemical abnormalities you would get with the different forms of primary hyperoxaluria, and we'll talk about that, except for pH3, which doesn't make a lot of sense, but we'll talk about that later. Now a little curveball. We'll talk about the biology of oxalate in different organisms, including plants, bugs, and planets. Not really organism, but just for fun. Because oxalate is not bad for everybody. It's bad for us. In fact, it's called the anti-nutrient. But for bugs, in particular. For example, the oxalate bacteria that you might have heard, because it's one way you could potentially modulate the oxalate load for humans. They use it for basically energy purposes. And what happens is they exchange oxalate for formate, and in the process generate ATP. And so if you have these bugs in your gut, in principle, you could consume oxalate from the nutrients you're getting and basically prevent the absorption. In plants, it has many functions that are often inferred based on what we think is going on, but by and large, it looks like it's involved in calcium fixation, heavy metal detoxification, and also in the form of crystals. It helps to prevent or make the experience uncomfortable for animals that are trying to chew on their leaves, because it creates little, almost like spears that are stored actually in these specialized cells called idioblasts. And this is what it looks like. So you can see here at the top, these cells are chock full with oxalate crystals. And at the bottom, you've got these spheres that I was telling you about, and you can anticipate that if you were to chew on this, you might not be a happy camper, but it's everywhere, in onions, peas, everywhere. So, and of course, it means that if we eat those things, we get our own load of oxalate. So I was telling you about oxalate being an anti-nutrient for humans, and the issue is we eat it, and we produce it through a variety of mechanisms, but about 20 to 30% is actually locally produced in you. The rest comes from your diet. And the fractional excretion in the kidney for oxalate is 90%. So basically, you almost excrete everything that you take. And it's the main route that we have for excretion of this anti-nutrient. The production that I was telling you about, that will become important later, because there are ways that you can have issues with higher oxalate levels in the blood that are related to the physiologic mechanism by which we can make oxalate ourselves. And also has relevance with some of the toxins that we are exposed as nephrologists. I'll move on to that. It's also on Mars. And actually, so that's been shown, through some fancy techniques that I don't understand, but allegedly it's there. And there's some recent experiments that show that you can create oxalate from just UV light exposure through different sort of compounds, including pyruvic acid. So it's really everywhere. And yeah, so I'll move on just for sake of time. So genetics. So this is just the historical picture of this condition. It was first described in 1925. It was recognized as a familial disease in 1950s. And the metabolic basis for it came shortly thereafter. You will hear about vitamin B6 responsiveness. So this is something that came along in the 1970s. And then the gene related to PH1, AGXT, this is in the 80s, PH2, 1990s, and PH3 only recently, just over 10 years ago. And the determination of which variant in AGXT predict response to vitamin B6. So this was in 2005. And this is important in terms of practical tips. So if you get one patient and they have one of these variants that respond to B6, it's important for you to know. So we need to look at some biochemical pathways, because will let you understand what's going on. So this is a hepatocyte with different organelles. You've got the cytosol also, you've got the peroxisomes, mitochondria, and the enzymes that play a critical role in this condition are labeled here. This is for PH1. And here, basically, the AGT is right here in the peroxisome. And here you can make some predictions as to what would happen if this enzyme is not working. Well, you will get increased glyoxylate levels, increased oxalate levels, and also increased glycolate levels. And this explains why we're doing some of these tests, because it will allow you to differentiate between the different subtypes. You can see here L-glycerate. Well, this will become important with a different one. It allows you to really distinguish which pH type you're dealing with. So speaking of which, whoops. Okay, pH 2. So now we're moving to the mitochondria, but you'll notice on the right-hand side that there's also the enzyme that is expressed also in the cytosol. And I will point out here that usually, so in the cytosol, it will take hydroxypyruvate and metabolize it to D-glycerate. So if this is not working, the default pathway through LDH is L-glycerate. And this is why we measure L-glycerate, because it will be useful to map out whether you're dealing with type 1 or type 2. Here again, oxalate level will be high, but glycolate level will be normal. So you're seeing a high, low sort of signature that allows you to distinguish quite elegantly what abnormality you're dealing with. pH 3 is the latest kid on the block, and I would say the most messy in terms of, it's not as elegant as trying to understand what's going on. And again, this is a problem in the mitochondria. And we definitely know that oxalate is elevated, but in terms of predicting the other abnormalities, it's a little bit, even the pathway to explain why oxalate is high is not super well understood, but the genetic evidence is quite robust. So why is it important to do genetic testing? And you might have heard that this is my thing, so I'm maybe a bit biased. But of course, confirmed diagnosis, prognostication is really key. Because if you're dealing with a patient with pH type 1, type 2, or type 3, it really has different impact on outcomes, on family planning, on treatment options. I mentioned about the B6 responsiveness. So here, identification of the specific variant is really critical. And these are some of the ones that are responsive to B6. And optimized matching to RNA interference therapies. So this is something we'll talk towards the end of the talk. And also transplant planning. This is really one of the key things right now also. So how to diagnose it? Well, we're back to, again, these biochemical pathways. So you basically are trying to figure out what is the signature that allows you to distinguish between the different subtypes. Here, I'm also showing you, so 1, 2, and 3 together, and you can see the arrows at different patterns. And for pH 3, there's a few other things you can measure, but the first 3, oxalate is okay to order in most hospitals, but it's actually in Canada, it's done in London, I think at Sick Kids. I'm not sure if you guys, maybe you send it to Mayo Clinic, but these are the main ones. And you have to know that the assays used in the different places are not the same. So the levels are not necessarily comparable. And we've done parallel experiments where we send the same sample from Sick Kids to Mayo Clinic, and the levels are relatively concordant, but not necessarily exactly the same. So you just need to be aware of that. And the other funky ones for pH 3, you can try to order them, but it probably will not be straightforward. So really the easiest thing is to do genetics, especially now that you can order it for free through NVCA via LNLM. So this is a paper that if you're interested to read about what sort of guidelines to treat these patients, this is from Europe in Nature Review Nephrology last year, and it's pretty well done. So we'll just go through it very quickly. But you've got sort of 3 major scenarios. So a patient that is of pediatric age with kidney stones or nephrocalcinosis and an EGFR that is low with some urine output. And the urine output here is important because it dictates what you can test. Because if there's no urine output, you need to do something else. You can't test urine. The other one is for the adult nephrologist in the crowd. If you have a older patient with recurrent kidney stones, nephrocalcinosis, and a EGFR of more than 30, because it's important, there's variety of flavors in this condition. Some of them are really severe, like the ones I see at Sick Kids, but the ones that the adult nephrologist will see is typically a much milder form. But the investigations are the same. Basically, it's testing urine for these metabolic signatures. In small children, you can do spot urine, but it's really important to do 2 creatinine ratios. And there's standard data for this. The other one is if you have basically a patient that is anuric, then you want to look at plasma. And we'll talk about some of these standardized values for this. And throughout the talk, I've put some QR codes. So if you want to just take some pictures, it will drive you straight to the paper. So if you make urine, then you test for the urine, you look for that signature. If you have normal urine oxalate, then you want to move on to the other forms of kidney stone issues. If you do have hyperoxaluria, then you do much more in-depth testing, including genetics. You can do the very detailed urine oxalate metabolites, and you could empirically start vitamin B6, even if you don't know the mutation, because it's pretty well tolerated, and then stop it if you find the mutation is not responsive. One thing that's really important is to rule out enteric hyperoxaluria versus the other types of pH. We'll talk about how to do that in a minute. There's some normative values for urine here for 24-hour collection, and also for spot urine sample for the different metabolites that we've discussed. So this is a paper, Nature Review Nephrology, that was mentioning these data. So if you need, it's there. And back to the case, remember the one we discussed earlier. I just wanted to emphasize here, now that we've talked about some of the values, you can see oxalate was very high, glycolate was high, glycerate was normal, and glyoxylate was normal, which point to a diagnosis of most likely pH1. How to rule out enteric hyperoxaluria. So, and this was, if you look at the Grossgrove paper, you need to do it for every form, which makes sense. So this is a little cartoon that I drew for myself just to kind of map things out so I could understand with, the different forms that you want in terms of primary versus secondary hyperoxaluria. So in terms of secondary, you can conceive it as different sort of physiologic process. The first one is increased oxalate precursors. So now you in your body, you'll have increased oxalate substrate, or something that will allow you to make oxalate, such as ethylene glycol, the toxins we mentioned earlier. Really, really important, vitamin C. This is probably the most common cause of hyperoxaluria or hyperoxalemia if you have high oxalate in the blood. And this was particularly prominent during COVID because there was some evidence that vitamin C could maybe help with this condition. Increased absorption of oxalate in the gut. This is your enteric hyperoxaluria. And basically, you can conceive it as different ways by which absorption will be modulated. IBD, leaky epithelia and inflammation, increased absorption. Calcium binding resins will decrease free calcium, which binds oxalate in the gut, so that you will get more free oxalate for absorption. And you can see a few of the other causes that all relate to phenomena that are playing a role in sort of fat or calcium binding, and thereby modulating the amount of free oxalate available for absorption. And then decreased factor for oxalate metabolism. This is B6 deficiency. Makes sense. We've already discussed that B6 is actually a therapy as a cofactor for AGT. And then decreased renal excretion. This is really important. It becomes particularly important when you have a patient, like many patients that might be in your dialysis units with undiagnosed end stage. How do you figure out whether they have high oxalate because they're in end stage, or they have high oxalate because they're in end stage because of primary hyperoxaluria? So speaking of which, what do you do if they have minimal or no urine production? So now you're stuck looking at plasma. Same biochemical signatures in a way, but in the urine, it's a bit more robust in terms of the patterns. And here, it's pretty much exactly the same, but this is the key piece of information. So what happens to oxalate in the plasma if you have CKD or a variety of GFR through CKD? And here in this graph, on the x-axis, you've got GFR, and on the y-axis, you've got plasma oxalate concentration in micromole per liter. And as you can appreciate with the black circles, the levels go up significantly with the GFR less than 20. The white circles, however, are patients with primary hyperoxaluria at a variety of GFRs. And I think you can appreciate that there appear to be a trend for levels in PH patients to be about twice as high. But it's not as robust as what we're seeing in the urine pattern. So you can potentially tell who is who, but it's not as robust in this case, because it definitely goes up in CKD. So important note. So there's good evidence that this condition is underdiagnosed, particularly in the adult patient population. In kids, they show up really sick with this most severe version. They're hard to miss. But with adult patients, there's fairly good evidence that it's a much milder disease that can be easily missed. And about 50% of these patients are diagnosed with end stage, so they've never been seen before. On the right-hand side here, I'm showing you the time of diagnosis versus the severity. So you can have the infancy presentation, which is the most severe. You can have it during childhood, adolescence, or adulthood. And the further away you are from the infant version, the milder it is. But your risk of end stage is still quite significant. The important note, number 2, is it's really critical to think about primary hyperoxaluria when you're doing a transplant, particularly when you're doing it in a patient with an unclear etiology for their end stage form. We got burned at Sick Kids, I think it was 15 years ago, where we had this exact situation. Patient had decreased kidney function post-transplant. And lo and behold, we ended up finding oxalate deposition through birefringence on microscopy. And we were kicking ourselves a little bit. And ever since, we've been doing this systematically on all biopsies. It doesn't take too much time, and it really makes sure that you're not missing cases, because especially now that we have much better therapies. So just something to check maybe with your pathologist if they're doing this systematically, because it's pretty straightforward, high yield. It's not subtle, as you can see. So something to note. So how are we doing for time? We started at 7:30. Right? Yeah. So now treatments. So here's I don't know if you're familiar with gene reviews. They're really excellent, freely accessible sort of chapters on different diseases. It's a bit like Up to Date, but free. And and here you've got really the big guys in the field, like John Liskey and Don Milliner, that are the authors of this paper that is updated constantly. So what are the recommended treatments? And again, this is from this Nature Review Nephrology article from the European group, just going down sort of their algorithm. But if you have hyperoxaluria, really the treatment approach will depend on which subtype you find in terms of B6, whether you give it or not, or whether you continue it or stop it. And then now there's the question that RNA interference therapy, like lumasiran and nedosiran, really the hot topic recently. And then the key question at the bottom of the right-hand side is, what do you do when your patient requires a kidney transplant? So the old way of doing things, as mentioned in the first case, was to do either a simultaneous liver kidney transplant or to do a sequential. And now we have the possibility of actually skipping the liver altogether and going straight for a kidney while on coverage through siRNA therapy. I can tell you that at Sick Kids, we learn the hard way that being able to do that is an immense luxury, because we had a child with this condition who actually unfortunately passed because the liver the anastomosis failed. So this was he was actually doing really well, but the first step was the liver in order to save his kidney. And unfortunately, it didn't work. The parents were aware of the risks, but it really showed us that if you could do without the liver, it would be a tremendous gain for patients. To lighten up things a little bit after saying that, a few pro tips to reduce input of oxalate for your patients, or for you if you feel like it. But there's some low oxalate foods And if you have a dietitian, they probably know all about this. You can also boil your food, makes it soggy and not so nice, but basically what it does is it solubilizes the oxalate that I showed you in these in those vegetables and fruits. Remember, it's everywhere. And also combined with calcium-rich food. Again, this makes sense based on what I told you about secondary hyperoxaluria, because calcium in the gut will bind oxalate, and you know where it's going after. Non-surgical approach, hyperhydration. So if your patient still has urine output, this will help prevent urinary calcium oxalate supersaturation, where it will basically deposit. Alkali citrate supplements will also do the same. Dietary oxalate restriction, based on the pro tips I showed you, may help, but it's really not, I mean, it's something you can do, but it's not necessarily going to have a major effect, just because if you have a bona fide primary hyperoxaluria process, the production, the local production is so overwhelming. And this will become important later. Vitamin B6 will decrease hepatic oxalate production if you have the right AGXT variant, because it has as a chaperone or as a cofactor, if you will, and it sort of helps the mutant AGXT to do its business. Hemodialysis, this is really important, because I find that, you know, and now since Liz sort of gave me the reign of her kingdom, I've been helping people, and I find that many of these patients are under-dialyzed, sometimes 3 times a week. Particularly in the phase before a transplant, it's really important to be quite aggressive with this, because you get ongoing production and you get release of accumulated oxalate through the tissues. And often physicians, when they start the siRNA therapy, they're surprised that the levels don't go down as much as they would like. And the issue is, if you have a patient that has been accumulating oxalate in all their tissues for 30 years, it will come down, but it will not come down to normal, because you have this release of stored oxalate throughout the tissues. B6, so we talked about it a bunch of times already, but there's actually in about 30% of patients, there might be a decrease in the responsiveness of the therapy, just something to be aware. But you need to try it for at least 3 months. The pyridoxine sensitive mutations are listed here, and that's pretty easy to find, and the dose is 5 to 20 milligram per kilo per dose. And as I mentioned, what it does is it acts as a cofactor for AGT. Dialysis, this is important. So you need frequent intensive dialysis. And the reason why I'm showing you these graphs here is just to show you that the clearance is very fast. Okay, so when you start dialysis, you're going to clear very rapidly a huge proportion of what's available for removal. And doing probably more than 2 hours is probably not very beneficial. You might need it for other reasons, but if you want to maximize removal of oxalate, doing three times a week with 3 hours is probably suboptimal compared to 5-6 times for 2 hours. It might be annoying to do it this much, but if you want to bring your numbers down on a patient that is on siRNA therapy, this is basically what you need to do. And remember, if you put a kidney in your patient, you're going to get accumulation of oxalate in the system, which could deposit in your kidney. So you really want to optimize this. And yeah, so what you need to think about is that there's generation of oxalate through hepatic production, but also this release from tissue. And here I'm showing you some data from a relatively old paper, but it's pretty impressive. And what they try to figure out is, here at the bottom, you've got different pH patients and also patients with end stage. And you can appreciate, let me see if I can do this. So your dialysis clearance, you see on patients, the numbers are not, the exact numbers are not particularly important. It's the sort of the scale. So you're in the 200s for the pH patients and the 60s for end stage. Generation rate is what the amount of oxalate that is produced, that they really calculated through some interesting physiologic equations, but it seemed to make sense. So that's why I'm showing you these numbers. But you can see the amount of production is through the roof. right, for the PH patients, which is not surprising, but it gives you a ballpark. In an end-stage patient, we're in the 20s. The other ones, you're 3, 500. And tissue deposition, this is what's going on dialysis, right? End-stage patient, minus 0.5. So you're doing a pretty darn good job clearing it. No surprise, because they're not making that much. And you're clearing, to use a scientific term, a crap load. Whereas with the PH patient, your dialysis clearance is overwhelmed by the production, right? And you get a lot accumulating in the tissue. And this is over years. And you can imagine your patient before that was not on dialysis. So all of the generation rate is, some of it will be excreted through the kidneys once they still have urine, but a lot of it will be stored in your tissues. But I think this is really important because it gives you a ballpark of what's going on. So the classic surgical approach, so we're still in the treatment phase. There was the combined liver kidney or sequential. And now there's been a few instances of kidney alone on the patient that is particularly responsive to B6. This was really rare. Okay, and you need to have some cojones to do this. So there's a question that often comes: should we do a nephrectomy? Because the kidneys are bright, they look like they're full of oxalate. In theory, it would be a nidus for release of humongous amounts of oxalate after, but it's really not a lot of good data for this, and it increases surgical risk, and whenever you do surgery, there's significant risk. So it makes sense intuitively, but the data is just not right there to really justify this. But something that often comes as a question. So now we come to sort of the hot topic, RNA interference, or siRNA therapy, or small interfering RNA. So we'll just review the biology because it's interesting and you should probably know a little bit about this. But basically, in a nutshell, what you do is you bring inside the cell of interest a small molecule called siRNA, or small interfering RNA, and it will basically bind to your target RNA for your gene of interest and trigger the machinery in the cell to basically recognize this as something that is not good and needs to be chopped up. And basically, you reduce gene expression that way. And the liver is excellent at picking up this kind of molecule. The delivery to the hepatocyte is absolutely amazing, which is very convenient for this condition. Doing this in the kidney would be much more challenging. And so there's two major therapies that have emerged so far. Lumasiran, which is made by Alnylam, the sponsor of this talk, targets. So here, the interesting thing is you target enzymes that are in the pathway, but are actually not the enzymes that are causing the problem. Remember, for PH1, the problem is with AGT, but the enzyme that we're targeting with the lumasiran is GO here. Okay. With nedosiran, it's a different part of the equation. What this siRNA therapy is targeting is LDH, which is one of the final enzyme for the production of oxalate from glyoxylate. Okay, so you just have to keep these concepts in your mind when you use these medications, and both of them are. So have been exposed to patients that are on both therapies. They seem to be both working well, and I'll show you. There's even a report where the physicians were not happy with a single therapy, and the patient ended up on both, which is a bit crazy, but it's been done. So here we go. So these are the two therapies that are available and basically are game changers. And there's been, we're not going to belabor this too much because the data is quite convincing, but there's been a lot of trials, particularly in the, not so much for the transplant part, but for the early part, to try to show that these therapies actually help reduce oxalate production and also help with basically preserving kidney function in your patients. So these are the various Illuminate trial for lumasiran. So there's A, and some data in New England Journal that was very impressive. So there's no question that it works. And the biology makes sense. Illuminate B, here they were, what basically the main differences between these ones are the who is in the trial. Here it was 39 patients more than 6 years old with an eGFR of 30 and a confirmed PH1 diagnosis. And for B, it was 18 patients, now less than 6, eGFR more than 45, again with a confirmed diagnosis. So different age groups, and the results basically are very similar. Eliminate C, now, so we're talking about eGFR less than 45 and whether they were on dialysis or not, okay? So there's been quite a bit of work to sort of flesh out the usefulness of lumasiran in these various patient population. And by and large, it's all, very positive. And so this is for nedosiran, made by Dicerna, and basically you're seeing exactly the same pattern. Okay, a bit less data for this one, and they're still doing studies. I'm not sure if they're still recruiting, but the patient I'm going to show you soon was actually part of one of their study, and it seemed to work quite well. So is it a game changer for PH1 patients with end stage? I would say for sure. It's been remarkable, but now what happens in the context of transplant? It's even more of a game changer because we can skip potentially this, the liver step, okay? And these are some of the reports that have been published. So there's not that many, but it's growing, and I'm sure I'm gonna show you 2 additional cases that we've helped with where we were successful and we're writing them up. But by and large, in all cases, there was no signs of oxalate nephropathy and at least 6 months of follow-up. And the proposed safe level of oxalate levels in the plasma for kidney alone transplant is less than 80 micromole per liter. I don't know if you remember the graph of the end stage levels, but a patient with end stage without primary hyperoxaluria, the top level was around 40, 50, okay? So not all that different from, that level initially was sort of set at 50, but it seemed to be too stringent. So the latest guidelines or sort of tips is less than 80 is probably safe. So it leads us to this cartoon here where now we've got this red box that appeared out of nowhere and is really a game changer, either with lumasiran or nedosiran. So here's some cases so we can, come back to the clinic a little bit. So this is a patient actually that was followed at SickKids as a child. And here I want to also point something out. So this child was seen in our clinic in nephrology, but because his problem was recurrent, really bad stones, he was actually mostly followed by urology, okay? So a lot of these patients are probably more in a urology clinic than in nephrology, because in this case, we transferred him at 18 to the adult world with very mild CKD. His GFR was basically normal, okay? So really our involvement was like, yes, thank you very much. You've got the disease. We come from the diagnosis. Hopefully you keep good function. Unfortunately, that's not how things unfolded. The other thing I would like to point out here, at the bottom here of the little timeline, you see liver biopsy. Okay, so this was the old way of diagnosing this condition before we had the genetics. Basically, what we had to do was to look at the enzymatic function in hepatocytes. So you need to do liver biopsy. So really, we've come a long way for, it's much less invasive. And we're generally touching the liver less, which is a good thing. So this patient developed CKD stage 4 at 24, and then was started on nedosiran around 27 and a half, and developed basically end stage like a month after, and was on a home hemodialysis. He was transplanted with a kidney from his mom, and basically has been doing very well. And then I put here at the bottom is genotype. So he's got actually a B6 sensitive mutation. So he's on vitamin B6 and siRNA therapy, and has been doing quite well. So this is the data. At the top, you've got the serum creatinine, which is what we'd like to see. A nice cliff You see here in the gray box that he got post-transplant intermittent hemo because the team was a little bit nervous because the creatinine seemed to be going back up and they started to like, oh my God. But this is pretty much standard. I would say that's what we've done in most cases that I've been involved with. There's a period on hemo just to keep things quiet, and there's a slow and steady sort of weaning. And then we kind of let them loose and we hope for the best. And it seems that it works in all cases that I've been involved with. At the bottom is the serum oxalate level. And I want you to get a ballpark here, right? We said less than 80 is fair game. So this one on nedosiran, I think his levels were 2 or 3 times higher without the treatment. And he did get a little bit more intense dialysis, as I mentioned before the transplant, because it was a planned transplant, so we could do this. It's a bit more difficult when you have a deceased donor because you can't really plan as much. But you can appreciate, I think, that the oxalate levels don't go back to normal, because normal is less than 5 or 6, but pretty darn close and stable. So pretty remarkable. So this is another case that we did a few months after. This is a 11-year-old female with end-stage kidney disease. And here again, I'm showing you this cartoon. So end stage, so she showed up in end stage at 11, was diagnosed. She started lumasiran like around 12 and ended up doing a living donor kidney transplant at 13. And you can see here that she got quite a bit of dialysis from diagnosis, in part because she was anuric, but also because we wanted to remove the oxalate. She was also on B6. And you can see also that we weaned her dialysis post-transplant. Initial presentation of creatinine was 800. She had very small hyperechogenic kidneys, no surprise there. And she was also a compound heterozygous for AGXT with a vitamin B6 sensitive mutation, the G170R, and a splice from her dad. So here, the lesson here, I think I've got the levels. Oh no, I don't have the levels. So the lesson here was that the levels were really fluctuating, and it didn't seem to be related to the distance to the dose of lumasiran. Because you would think intuitively, if you give the lumasiran on Monday and you do the levels 2 weeks later, and then a month later, it should correlate with the timing of the dose. It doesn't appear to be the case. I'm not too sure why, but here she was fluctuating between 37 and 61, and the team was a bit nervous because 61 doesn't seem to be as nice as 37. But nevertheless, she did very well, and again, remember, the less than 80, I think still this case also proves that less than 80 is fair game. So while we were planning this, we were thinking about contingency plans because you still, we've got just over 10 cases reported in the literature, including ours that should be coming out soon. So it's not that much, right? So we were a bit nervous. And we're trying to think, so what can we do if things don't go as well as we would like? So this is the patient that was on both therapies. And let me go through this. So these are plasma oxalate levels. The little white bar on the left-hand side is on nothing. So levels were very high, 240, right? Remember, a end-stage patient would be, 4 times less than that. The light gray is on lumasiran. You can see a nice cliff, right? But they were nervous because now they were hovering around 100. And this is 2023, so it was not too clear what the cutoff should be. So somehow, I'm not too sure how, they probably got it through compassionate access because the cost for this would be through the roof. She ended up on both, and it didn't really change that much, as you can see. It dropped in the 70s, and then they proceeded with a transplant, and she did remarkably well. At the bottom here, I put the upper limit of normal for normal people. So she's basically almost normal, okay? So whether that's due to the fact that she's on both, it's possible. I spoke actually to the investigator at a meeting And the goal is they don't feel that they can remove any of the therapies. So she's stuck on that for now. But it's probably going to be one of the only cases. This is another one that's interesting. And basically, they use stiripentol to inhibit LDH. Remember, LDH is the enzyme that is targeted by nedosiran, the final enzyme that takes dioxalate to oxalate. And here the rationale was that I think they knew about this. They didn't have access to lumasiran yet. So they used it as a bridging measure to see. So yes, the patient was one in B6, they add stiripentol, and then they added lumasiran on top of that. I can tell you, we thought about this. It looked nice. It looked like, it could make sense. Not exactly easy to get this medication for sort of, it was actually, we could not get it. So it's nice. You can try, maybe different provinces is different. But this is something you want to do well ahead of time, right? To see, okay, what levers can we pull and push if we need to. So this is again, the 11-year-old that we transplanted. And you can see here, so at the top is the serum creatinine. So for us, it's acceptable, level of 100. We'd like a little bit lower. Her serum oxalate levels have been sort of dropping down. I think now she's less than 10. So this is, I didn't update the graph, but this is from August. And this is off dialysis, right? So it's pretty darn good. The other thing I should point out is both patients ended up getting early biopsies within 3 months, and then another biopsy later. And I can tell you, we saw oxalate in both kidneys early, and we saw no oxalate in the later biopsies. Okay, so no need to freak out. It's probably going to be there because there's lots coming out from the tissues. And certainly there's a path. Remember, the fractional excretion of oxalate is 90% is through the kidneys. So if you've got the new kidney that's working, there's going to be a flood of oxalate going through. So I think we're doing pretty good. So there's a few take-home points. So it's a rare disorder of glycosate metabolism that leads to high oxalate levels. There's 3 types. And PH1 accounts for 80% and is the most severe. The delays in diagnosis are common because the clinical presentation is very heterogeneous and non-specific, and the disease severity is variable. There's no clear association between genotype and phenotype. Delays in starting a treatment increases the risk of end-stage and systemic oxalosis. And now that we can start things early with SNRI therapy, hopefully we can reduce this. There's recent changes in how patients are diagnosed. No more liver biopsy, thank God. And managed, no more liver transplant for the most part. Although I can tell you, there's still quite a few people that are very nervous about going without a liver transplant. It's critical to think about ruling out primary hyperoxaluria when dealing with patients with undiagnosed end-stage, especially when planning for a kidney transplant. Really important. Ask your kidney pathologist about systematically looking for birefringence on kidney biopsies. And don't hesitate to ask for help from colleagues who have experience dealing with PH. I would say that if you take care of one patient in a longitudinal fashion, it's just an N of 1, but you almost become an expert. Okay, and then if you do more than 1 and 3 and 5, then it really gives you a very good impetus to read the literature because you feel like I need to know about this. So I think most people that deal with this disease become de facto experts and feel a lot more comfortable. So what's on the horizon? So more frequent, or I would say ideally only kidney alone transplants done in a safe fashion. Ideally more diagnoses of PH patients in adult population. Treat or start RNA high therapies for younger patients. So maybe we don't need any transplant. Then these combination therapies, maybe stiripentol could be a nice addition if we could show that it's well tolerated and that acting on 2 pathways at the same time, let's say with lumasiran and stiripentol together, might be a nice way to go. And everybody has heard about CRISPRs. CRISPR, where you can basically go in a cell and basically edit the genome. Well, now that we know that messing around with the mRNA of a variety of enzymes in the hepatocyte is very helpful, but requires, multiple injections for life, it could make sense to just go straight to the master and just basically create a knockout for these genes. And there's quite a bit of work on this, particularly because CRISPR delivery to the hepatocyte is very, very good. So stay tuned, because I think in the next 5 years, it's probably going to be something that will be done. So I'll be happy to take some questions, and hopefully you learn something. Thank you.
So we start a little bit late, so we do have some questions. So we do have some time for questions, and I think it's another reminder of how much nephrology's changed in the last 5 years, like the technology, the diagnostic abilities, et cetera. Mike.
Yeah, thanks for that. Yeah, I'm on. Really great presentation. Lots of questions bouncing around. I'm an adult nephrologist. Just one of the thoughts I have is we do run a metabolic stone clinic here. And obviously that would be a gate point for case findings. But I'm also struck by the fact that we can't get a urine oxalate on our patients on a 24-hour collection because we're told there's a worldwide shortage of the reagent. So when we order it, it just comes back as not available. So I'm wondering if you have any suggestions or thoughts about how you're actually case finding if urine oxalate isn't available for looking at that. And obviously we can't be sending, or I don't think we can be sending all these patients off for genetic testing or serum oxalate levels. But without that piece of information, how do we find these cases?
Yeah, thanks. I think anybody that's tried to send it, I think in the past 3 or 4 months, has been hitting a bit of a wall. But one reminder, I think these assays are used at CaNGen in London, but at Mayo use a different approach. So if you have a channel, I know for us, sometimes we can do it locally, and it ends up we're getting a report from Mayo. It's more expensive, but if you need it, it's doable. I think the shortage is about to get better. And I can tell you, especially if you're going to do a transplant, the CaNGen gang has been pretty good to be flexible, because usually what happens is all these centers, they accumulate all the samples from everywhere and they run a batch, which means that you get, you might have sent your sample January 1st, but they run it January 30th. So thank you very much. If you want to get timely results, it's not going to happen. But CaNGen has been good. So for the first, the case on nedosiran, they agreed for us to accumulate a bunch of samples over a week, and then they would run it, and we'd get the results a few days later, exceptionally, just because they knew the stakes were high. So you might be able to do that using our lab. For genetics, unless things have changed, and from what I hear, it hasn't, you can get kits from Invitier through Alnylam, and it's free. So you can bypass all of you can still need to do paperwork and all of that, but as far as I know, you don't need to ask for, every province to defray the costs. So in principle, I think if you have if you think that you're dealing with a patient with PH, I would just straight go to genetics. That's right? Still, I think we have those kits. You can just, I think I got it in the mail. You're still doing the same thing? Yeah, so anybody that wants to do it, you can just get in touch with Alnylam and you'll get the kits from Invitier. And but it's a very good question. Yeah.
So yeah,
Somebody, can you mute yourselves, UNHBC? Thank you.
Got it. Okay, hi, Mathieu. That was great. I'm a hematologist, as you know, so this is all new to me. I have 3 really quick questions. One, with these elevations in oxalates, do you see any chelation of other anions? And do you see coagulopathies? Do you see symptoms of hypomagnesemia? or zinc, any effects on that? Second one is I'm struck that you're only talking about kidney. Are there effects on other organs, on the eyes, the brain? I know there's a reason for the kidneys to be involved.
Yeah.
And third, are there any downsides of having low oxalate levels?
So three very, very good questions. For the first one, about the, let's say, the hematological impact or interactions with other, ions, I'm not aware, but I'm sure there's pretty complex biology going on. And of course, my focus was on the kidney, but this is a systemic disease. And it just so happens that because the kidney is the main conduit for excretion, it's the main side effects. But yes, it affects all the tissues just because you get accumulation everywhere. And your last question was about
low levels.
Oh yeah, excellent
Which
question.
is an implication for treatment. I mean, if you can knock it down low, you got a great, and it's in the liver particularly, it makes a great target.
It's a good question. I'm not aware that there's any particular problems when it's too low, and there's in contrast to plants and bugs, we don't have a particular use for it. So that's why it's like I was mentioning, many people in the field call it the anti-nutrient I saw a talk by some people might know of Orson Moe, who's a prominent stone researcher, who's actually from Toronto, but is in the States. And one of his questions was,
UNBC, can you mute, please?
So one of his questions, why, it must be doing something for us. But as far as I know, and as far as when I saw his talk about this, it's not entirely clear what that would be, but there's clearly something. So too low might not be a good idea. And in fact, in most people, it's never zero. So even with perfectly normal kidney function, all very good questions.
Mark Elliott has a question. If you want to read it out, Brenda.
Okay. So Mark Elliott says, thanks for the excellent talk. For PH1 patients, how do you choose between lamicin and endocerin?
Oh, how do you choose?
That's what
it's a very good question, Mark. So basically, you take whatever you can, basically. So if in some provinces, it's not covered. And I think is it covered here? Or is it less than 18? No? Okay. So ideally, you get it through compassionate access or through a study. And then you, like the patient I told you about that was on nedosiran, that was the only way at the time that he could get on treatment. It was part of a study, so it was that way. Hopefully things will change. I think the data is so strong that I would think that the different provincial regulators are going to change their mind, especially if you can prevent dialysis and transplant, because you're saving a lot of cost to the system. But basically, and I think, Mark, you just went through this with one of your patients who's on lumasiran, I think.
Private insurance.
Oh, through private insurance. Here you go. So yeah, I guess this patient was lucky, but very good question. Any other questions?
No, thank you for an excellent talk. And thank you very much for putting all the thought into it and also stimulating us to think about, I think in the adults, it's more subtle. And I think it takes us back to going to our clinics with all our adults who have these kind of funny things and not quite right, that we might actually think more clearly about it. Dr. Singh and I had a very dramatic case when back in the 90s of a lady that presented at the age of 40 with acute kidney failure, which was secondary to primary hyperoxalosis. And she had lividoreticularis and a number of other systemic features when she presented. And I forget what the precipitant was. She had an illness of some sort. It was very odd. But so I think we need our alert buttons up a little bit for looking for some of these cases. But thank you again, and thank you for sponsoring it. And yeah, stay tuned.
Thanks, guys.